Peutz-Jeghers syndrome is a rare genetic condition characterized by hematomatous polyps throughout the gastrointestinal tract. These polyps can lead to chronic anemia, intussusception, and bowel obstruction. Traditional hot snare polypectomy carries a heightened risk in the small bowel because its thinner, more vascular wall allows deeper thermal penetration, increasing the likelihood of injury, bleeding, and perforation. This is further amplified in children where thinner intestinal walls, narrower lumens, and a smaller, more mobile abdominal cavity make procedures more challenging, especially with adult-sized enteroscopes and equipment. Ischemic polypectomy offers a cautery-free alternative by mechanically strangulating the polyp stalk with either a detachable snare or hemostatic clips. While this approach has been described in adults, its use in pediatric patients is rarely reported and has not been previously demonstrated on video. We present the case of a 12-year-old girl with Peutz-Jeghers syndrome and chronic iron deficiency anemia. Capsule endoscopy revealed multiple pedunculated polyps throughout the small bowel. Several of these polyps are visualized here. Single balloon enteroscopy was performed under general anesthesia using CO2 for insufflation. 7 large duodenal and jejunal polyps were identified and treated using ischemic polypectomy. A detachable snare was deployed at the base of the stalk and cinched tightly until a dusky color change confirmed adequate ischemia. Polyp autoamputation was expected within 2 to 3 weeks. The snare approach was chosen in this case for efficiency and to reduce the number of devices required, though a hemostatic clip approach can also be utilized. In one instance, a second snare was applied due to equipment malfunction with incomplete deployment of the first device. This video demonstrates 3 representative polypectomies. Corresponding maneuvers on the device handle are shown alongside the endoscopic videos. In this example, a 20 mm pedunculated jejunal polyp was selected for ischemic polypectomy. Initially, a detachable snare was carefully positioned on the stalk with the fulcrum of the device placed at the intended location for snare placement. As the snare was gradually tightened, a subtle dusky color change developed across the polyp head, indicating early ischemia. However, despite correct positioning and tension, the cinch mechanism failed to deploy due to a technical malfunction. Although the cinch eventually deployed, it did not achieve the intended tension. Consequently, perfusion returned over the next several seconds, and the polyp regained its original coloration, indicating a loss of ischemia. The snare was then carefully deployed. A second detachable snare was then introduced and again positioned securely at the base of the same polyp stalk. As the snare was tightened, progressive blanching and dusky discoloration of the polyp were again observed. This time, the cinch deployed successfully, resulting in stable placement of the snare and complete loss of perfusion to the polyp. The ischemic effect was maintained, and no immediate complications were noted. In the second case, a 15 mm pedunculated polyp was identified in the jejunum. In this example, the tail from a detachable snare used on a separate nearby polyp is visible in the procedural field. A detachable snare was positioned at the base of the stalk, and the device deployed without complication. A dusky color change was observed following cinching, consistent with effective ischemia. The third case involved a 10 mm pedunculated polyp in the duodenum. The ischemic polypectomy technique was again employed with successful snare placement and prompt development of appropriate color change, indicating loss of perfusion. The patient's chronic anemia had improved at 6 weeks with an increase in hemoglobin from 9.1 to 12.4 grams per deciliter. There were no bleeding or perforation events. Repeat capsule endoscopy was planned for around 2 to 3 months post-procedure. Potential risks of ischemic polypectomy include delayed bleeding, device failure, and incomplete ischemia. The main limitation is inability to retrieve polyps for histology. Though in confirmed PJS, histology is less critical, and targeted biopsies can be taken if concerning features are present. In summary, ischemic polypectomy appears to be a feasible and safe option for removal of small bowel polyps in pediatric Peutz-Jeghers syndrome, minimizing risks of thermal injury in the small intestine. Visual confirmation of ischemia is essential for procedural success, and repeat snare placement may be needed in some cases.